So Dr. Omondi is going to talk to us about the relationship between COVID and rheumatic diseases, if there's any impact in between them, and what is happening in there. As you are aware, this disease, the pandemic, is something that is unraveling. Everybody is struggling, especially the experts are struggling to understand it, to understand its impacts, its implications. So there are many things, there are many diseases that people have, the comorbidities that are there. So we as Africa Science Media Center, we are trying our best to get the best scientists to be able to talk about some of these issues so that they can explain it to you, the journalists, so that you can be able to express it in the best way possible to your audiences to enable understanding so that people can make decisions from a point of information. So I'll stop there. Dr. Omondi, you can introduce yourself better than I have and proceed to make your presentation. After that, there will be a session for question and answers. You will then talk when you reach there. Thank you very much, Dr. Omondi.
Thank you so much, Daniel. As you said, I'm a physician and a rheumatologist based in Kisumu. And I trained from University of Nairobi, then went to India and did my rheumatology there. If you know, Vellore is in southern India. It's a bit of a warm place, so it was nice being there. Almost like Kisumu, just slightly hotter. I've been teaching medicine here in Kisumu, a university called Uzima, for 6 years, and I'm still continuing. Apart from that, I also have duties at the main government hospital in Kisumu. It's now called Jaramogi Odinga Odinga Teaching and Referral Hospital. So that's where most of our students take their lessons, their clinical lessons. Also, apart from that, I'm also honorary at Maseno, also medicine. So I'm lucky that I teach in two different universities. So I'm able to learn from both sets, government and private. So our topic today is COVID and how it relates or how it affects rheumatic diseases. So first, I should explain what rheumatic diseases are. Usually, your body does not react against the body. So any disease which is due to reaction from body, then that's what we call rheumatic disease. And there are many, including rheumatoid arthritis, even gout, even one called systemic lupus. So any disease where there is autoimmunity, we call it autoimmunity or self-immunity, then that's gout. He has already shared my disclosures. So this is the outline. We are going to have some introduction on COVID and some of the drugs used in rheumatic diseases which were thought could have an impact in COVID. Then also there was a fear that the immunosuppression in rheumatic disease would cause the COVID to be worse in rheumatic disease. Then there's also the effect of COVID disease on rheumatic diseases. Then we shall look at some of the recommendations on COVID disease. Next. So COVID is a virus which originated in China, Wuhan, and the scientific name is SARS-CoV-2. That is the scientific name of the coronavirus. And so it spread so fast. Initially, it was not so well understood. And so up to now, what we call how the virus works, how the virus works or causes disease, that's what we call pathophysiologic, is not yet well understood, because in some people it's causing mainly heart, some people rest. Now it's causing more of also like nerve disease. So one virus having so many complications. So we haven't really understood a bit of a lot why it should be able to do all that. We know it affects mainly people with comorbidities, and hypertension being the largest, then diabetes, then also people with heart failure, and also people with stroke. So those are the main groups of people who are badly affected or who have a worse outcome. So initially when the disease started, we thought that even patients with the rheumatic disease would be affected. We shall see how it turned out. So this is the cause of the disease, the stages, but it doesn't always follow this disease. So stage 1 is normally asymptomatic. Then you may have non-severe disease. Then you have severe respiratory disease. Asymptomatic is clear to everybody, where you don't have any symptoms. It's only the test which is positive. Then the distinction between stage 2, non-severe, and severe is what we call oxygen saturation. So if you have oxygen saturation below 85, then we call it severe. If it's 85 and above, then that's non-severe. That's the distinction. And you can see things get worse between stage 2 and stage 3. We haven't really delineated exactly at what time, but between when the oxygen saturation is between 85 and less, then you start getting worried. You watch the patient. Those are the kind of people you're admitting to the hospital. Next slide. So when COVID started, a lot of drugs were thought to have worked. Actually, we went into a shortage of hydroxychloroquine because initially when it started, there was a big study which showed hydroxychloroquine was working, and suddenly we went out of stock of hydroxychloroquine, and our patients who have SLE and rheumatic disease and SLE and rheumatoid arthritis had a lot of problems. Later, of course, the study came out that had some technical errors, and it was withdrawn. So initially, HCQ was thought to be beneficial. So after that study then was withdrawn, then everybody now is not using HCQ for treatment or prevention of COVID. But when it started, there were large studies which had showed it was useful. So now HCQ is back in the pharmacies, and our patients have the drug, which is quite a good thing. Then there's a group of drugs called JAK inhibitors. Sorry, there's a lot of science involved in this. Maybe if there are a group of drugs called JAK inhibitors. The one which is now commonly used in COVID is called tocilizumab. JAK inhibitors just they inhibit some pathways in the nucleus. That's what I can say. They inhibit, in simple terms, they inhibit nuclear signals. So I didn't want to go so much deep into it, but if there are questions, then I'll be able to take. Yeah, so they inhibit the final pathways of final pathways of nuclear transmission, or of message transmission from the nucleus. So they are called JAK inhibitors. Then interleukin-6 inhibitors are drugs. Interleukin-6 is a messenger from either the T cell, so or some cells. Some cells, we call them cells which produce cytokines. The commonest is a T cell. So interleukin 6 also is associated with a lot of bad outcomes. So also it's used. I'm sorry, I made a mistake. Uh, uh, Tocilizumab is a interleukin 6 inhibitor, not a JAK inhibitors. JAK inhibitors are drugs like baricitinib. So please correct, tocilizumab is an interleukin 6 inhibitors, and that one is used in COVID. Even in our center, we are using it because it has shown to have some good outcome. So this slide has two purposes. One, it shows you how the COVID virus enters into the cell. Sorry, it's a very technical slide. So you can see using the pointer, the red circled spikes is a COVID virus. Then it has these spikes called S spikes. These are the ones which are attached to the receptor. The receptor is called SCE2 receptors. So that's where it attaches to. Then it's taken into the cell. Then it uses the human gene to replicate itself, almost like HIV. So that's what it happens. So it's taken in by the AC2 inhibitor. Then it goes into, if you can remember your biology, some of you have done microbiology, so you understand this. It's taken into the endoplastic reticulum, and using the mechanism of the cell, it's translated to the nucleus, and it acts like an mRNA, so causing the cell to produce more of the virus. Yeah, so that's how it acts. So the other thing this slide shows is where particular drugs work and where they thought. So if you look at HCQ was thought to work. This is where HCQ works in rheumatic disease, in the endoplastic reticulum. It lowers the pH. So that's where HCQ works, and causes the virus not to be translated into the nucleus from the endoplastic reticulum. So by increasing the pH, it causes the virus not it causes the virus not to be translated to the nucleus. Then this is where the JAK inhibitors work in the nucleus. They inhibit the final translation of the message. So a common drug of JAK inhibitors like baricitinib, which there are three JAKs. So there's JAK1, JAK2, and JAK3. So baricitinib also works in COVID because it inhibits JAK1 and JAK2. Then the other drug which we are using in our center is tocilizumab, which blocks interleukin 6. So interleukin 6 is interleukin 6. It's a transmitter for transmitter for. Usually you have good transmitters, or good transmitters and bad transmitters. That's how I can say it in layman terms. So the bad transmitters are things like interleukin 6, interleukin 10. Those are bad transmitters. Then you have the good transmitters like interleukin 12. So if you transmit interleukin 6, you have bad outcomes. Like for example, in rheumatoid arthritis, it will cause joint swelling. It will cause skin issues. Those are interleukin 6. So it's associated with bad outcome. Then you have the good transmitters, like interleukin 12. So again, if you inhibit interleukin 6, it has a better outcome. And so a drug like tocilizumab is also used in rheumatic diseases. And so for us who are in practice, we have seen it, it has some good outcome in COVID patients. Yeah. So again, it's thought that vitamin D is a good, it's used in good transmission. So vitamin D improves immunity. So we are encouraging people to take vitamin D during COVID and vitamin C. So what we feared in COVID is the immunosuppression, that anybody who is in an immunosuppressed state could have worse outcome. So in rheumatic diseases, these are the three ways in which immunosuppression comes by. So you can either have the rheumatic disease causing direct immunosuppression. So rheumatic disease causing direct immunosuppression. A good example is systemic lupus. That's what we call SLE. It causes direct immunosuppression through different mechanisms. Then also another way in which immunosuppression occurs is if you have another immunosuppressive disease in a rheumatic disease which does not cause immunosuppression. Like for example, gout does not cause direct immunosuppression. But if you have diabetes on top of gout, then you'll have a disease causing immunosuppression in a non-immunosuppressive rheumatic disease. That's the example I've given there. Diabetes mellitus causing immunosuppression in a patient who has gout. Or if you have malignancy in a disease in gout, again, you'll have immunosuppression. And the biggest chunk of immunosuppression is through the drugs. Most of the drugs we used in rheumatic diseases, for example, steroids, interleukin inhibitors, and also JAK inhibitors also cause immunosuppression. So our fear was that if you have immunosuppression, you may have bad outcomes with COVID disease. Next slide. So these are the major things we feared in rheumatic disease and COVID. One, we had a fear that the risk of infection, the risk of COVID infection in rheumatic disease will be high. The other fear was that the COVID will be much severe in patients with rheumatic disease. And the third thing we feared was that the use of steroids, in COVID will cause the disease to have a bad outcome, which turned to be the opposite. As you'll see that the use of steroids turned out to be useful in COVID. Next slide. So the best way is to refer to some few studies. One was the risk of infection with COVID in patients with the rheumatic disease. Again, there were two large studies, one in China. And after following up prospectively patients with the rheumatic disease and the infection in COVID, it did not appear that the presence of rheumatic disease increased risk of COVID. So we were very happy when these studies came out that the presence of rheumatic disease does not appear to increase COVID infection. Next slide. Again, yeah, this was a study from Italy, a very large study. And again, they were looking that they were following up patients to see if you had a rheumatic disease, if it increased your risk for COVID-19. Again, okay, this was a different study on the effect of COVID on the disease, again from Italy. And after following up patients with the rheumatic disease and comparing them with the normal controls, they took patients who had COVID and rheumatic disease, and patients who had only COVID and no rheumatic disease, and they followed them up for some time. Next slide. Next slide. So this is what they were trying to do. So they followed patients who had COVID symptoms and rheumatic disease, and patients who had COVID and did not have rheumatic disease. And they tried to see the outcome. The initial number of patients was that 527. And so they followed them up. And this slide gives you the exclusion. And actually they did a PCR, a nasal swab. And you can see the ones who never had, usually the rheumatic diseases are few in the population, about 1%. So they have to be fewer patients with rheumatic disease. Next slide. Sorry, again, in science, you have to compare the population so that we just see that the populations were uniform in most characteristics. So that's what this slide is trying to demonstrate. The ones with autoimmune disease with no COVID, and the ones with autoimmune disease with COVID, and again we compare. And they seem to be similar in most characteristics. So finally, when they did all that analysis, and they found that the infection in the people with the COVID disease was only 0.22%, and again in the general population was almost the same. So whether you had a rheumatic disease or not, the infection did not seem to be increased. And that's the conclusion, that patients with rheumatic disease do not seem to carry an increased risk of infection compared to general population. So this was a very good study because there was a very high fear among our patients that they shouldn't come to the hospital because they're going to get COVID. So after this, we were able to advise them that the risk does not seem to be larger than the general population. Next slide. Again, this was supported by other studies. If you're in medicine, then you'll know that New England Journal of Medicine is one of the journals, what we call a high impact factor. Next slide. Next slide. Then there was also the fear that the severity of the disease, of the COVID infection, will be very high in patients with the rheumatic disease. And this was based on that other infections normally are more severe in patients with rheumatic disease. So there was, again, a very large study from northern Italy, a place called Lombardy, and they followed up patients with the rheumatic disease and normal patients without rheumatic disease. So that's what we call a case control study. So you take the same a population with the disease and a population without the disease, and you match them. You match them in age, sex, and sometimes even in race. Then you follow them up over time. Then you see the outcome. So that's what is called a case control study. So they match them, the population, then they follow them up. Next slide. So after matching the population, and usually the controls use a higher ratio, usually use 1:2 or 1:3. So for every rheumatic patient with COVID, you use a normal population, three or two of the normal population, and you match. So after they followed up the population, the final conclusion was that in these patients with rheumatic disease and musculoskeletal disease in a geographic region with a high prevalence of COVID, a poor outcome seems to be associated with older age and the presence of other comorbidities, but not presence or type of rheumatic disease. So that's what they found in Lombardy, that it's not the rheumatic disease itself which makes your disease worse, but usually it's older age and the usual comorbidities we mentioned at the beginning, which is hypertension, diabetes, previous stroke, or diabetes, hypertension, previous stroke, or if you have cardiac failure. So again, this was a very good study for patients with rheumatic disease because you are able with confidence to tell them to come to the hospital. So COVID does not appear to be more severe in patients with rheumatic disease. Again, there were two studies, extra studies, which supported that. Yeah. Again, arthritis rheumatology is also a big journal for patients who are following, for people in rheumatology. So, effect of COVID-19 on treatment. So after all these studies were done, so the body which like regulates rheumatology practice in US, it's called American College of Rheumatology, ACR. They came up with some guidelines based on the available data that, again, these are some of the recommendations they come with. The first recommendation was that the risk of poor outcomes from COVID was not primarily related to the disease, to rheumatic disease, but to other risk factors such as age and comorbidity. And normally we normally score the guideline as either high, low, or moderate. So this one was scored high, that it's not the rheumatic disease causing the poor outcome. Then also, they advise that select measures to reduce healthcare encounters may be reasonable, so that it was not necessary for the patients who have stable disease to come to the hospital, but they could be monitored through what we call telemedicine or telehealth. So, like, for example, the patient could go to a lab, do the test, send it through email or WhatsApp, then you could advise. And again, that was called moderate to high, that recommendation. Then the third one was one which had a lot of importance because we use a lot of glucocorticoids. The other name is steroids. So a good example of steroids, it's like dexamethasone. So we use them a lot for treatment of rheumatic disease. And because we had seen, this one was before it was shown that glucocorticoids are useful. So they advised that steroids should be used at lowest dose possible, regardless of exposure or infection status. So initially there was a fear that if you had the COVID, you should stop steroids. So at that time, we didn't know that steroids would be useful, but they had advised, no, don't stop steroids, just reduce them. So, and this one was called moderate to high. So at that time, we didn't stop steroids, we just continued. Next slide. Again, that's what you have said. There was a fear. We know 6 months later, it was shown that steroids were useful. and we were very happy because now we knew if our patient had steroids, uh, um, if they got COVID, severe COVID while they were on steroids, we had thought the outcomes would be better. So glucocorticoids should not be abruptly stopped, regardless of exposure and infection status. So even if you got COVID while you're on steroids, we just had to reduce them, but not stop them abruptly. Then number 5 was also very interesting. Recommendation number 5. If you can remember that busy chart where we were showing that COVID, the SARS-CoV-2 virus uses AC2 receptors to get into the cell, then we were afraid that if we continued using AC inhibitors, then the patient will have bad outcomes. But the other studies which I didn't show that showed that, again, whether you used AC2 inhibitors, your outcome was just the same as the ones who are not on AC inhibitors. So again, that one we continued with the AC inhibitors. Okay, AC inhibitors are drugs used to treat hypertension. A good example is like enalapril. So we call them AC inhibitors. In full name is they're called angiotensin converting enzyme inhibitors. So again, we were not supposed to stop them abruptly. Basically, this slide was saying that they told us if you're on the drugs, you shouldn't stop them immediately. You should just taper them down. Later again, it proved that some drugs were actually useful, like steroids and interleukin-6 inhibitors, like tocilizumab. They proved to be useful. Next slide. Next slide, please. So, 1 year down the line, after having so many, 1 year down the line post-COVID, this came out in May, either May or early June this year, 2021. Again, ACR is American College of Rheumatology. So they came up with these guidelines after about 1 year of seeing how COVID progressed. Okay, after 1 year of seeing how COVID progressed, and after seeing how the vaccination in between, I think 6 months below after COVID started, the vaccines were available. And so there was a fear that some of the drugs used in management of rheumatoid arthritis would affect the COVID vaccination, which again was proved to be true. So I know some of these terms are technical, but we can go through them. So hydroxychloroquine is an anti-malaria drug, a brother to chloroquine. Chloroquine, we know it has been in Kenya for some time and has been used for many years until it was withdrawn in the late 90s. So the use of vaccines and hydroxychloroquine and steroids and steroids less than 20 milligrams equivalent of prednisolone. Again, that one, you don't need to worry, just take your vaccine as scheduled. So even if you take the vaccine today, you can continue with your HCQ, or you can continue with your steroid doses if they're less than 20 milligrams per day. That was the recommendation as of June this year. Then there were some other drugs. One is called leflunomide, one is called mycophenolate, and one is called azathioprine. All these drugs, they're in a group called immunosuppressants. Again, they said if you are unstable, if your disease is stable, then there's no need to stop them or modify them. you just take your vaccines as uh, as planned. But if your disease is unstable, then either you postpone the vaccine or you postpone the vaccine and continue the drugs. The drug which they had a lot of challenge with was methotrexate, because actually it is shown to impact the virus. And so if you're going to have the vaccine, you have the vaccine today, then you have to postpone your methotrexate for 1 week after having the vaccination. The same also for JAK kinase inhibitors. If you're going to have your vaccine today, you have to postpone your JAK kinase by 1 week. Then there's another drug called abatacept. Again, depending, it can either be given intravenously or subcutaneous. Intravenous is through the vein, subcutaneous is under the skin. So if you're going to get the vaccine, then if you're giving the drug subcutaneous, then you have to postpone the first dose of the vaccine only, usually by 1 week. But after getting the first dose, the second dose, there's no need to postpone it if you're on that drug called abatacept subcutaneous. But if you're going to give it IV, then you need to postpone the drug by 4 weeks if you're giving it intravenously. Yeah. Basically, these were the recommendations depending on SCR classification. So basically, what have we learned from the COVID and the rheumatic disease? Actually, what you have learned is that it is not impacting the rheumatic disease worse than the general population. The other thing we have learned is that some drugs used for rheumatic diseases have proven to be effective in COVID. For example, the steroids. And also in our center, although it's not supported by large-scale data, we are using tocilizumab for severe COVID in our center. Next slide. So basically, I wanted to stop there so that it's a very scientific presentation. So I wanted maybe to take the questions. But in summary, what you've learned that COVID is a serious challenge. Even up to now in our center, we are still struggling with some issues. The pandemic has challenged total clinical practice, including rheumatology. And in our practice, we tend to agree that it's wise to follow established guidelines. Like for now, we are just following the American College of Rheumatology guidelines. So, sorry, it was a very scientific presentation for people not into science, but I could get some questions to break it down. Thank you so much.